Yeah, live.
You're live now, ma'am.
Good evening, everyone. So, welcome to our another episode of Contact Lens Learning course program. And this is the second part of our lecture series on um, orthokeratology. And we have two esteemed speakers for that. In the first lecture, there was a brief introduction about what is orthokeratology and what all things are going to be there. This is a continuity of that lecture only. Dr. Chris and Dr. Arthur, thank you so much for sparing your valuable time for Delhi Ophthalmological Society. And just to remind you, our viewers have joined in a different platform. Here on the speakers and panelists will be here. And I have with me Dr. Anu Malik, our executive member of Delhi Ophthalmological Society. And Dr. Anu Malik, I'll request you to please introduce our speakers and the panelists for today. Then we'll move on with the lecture. And Sharik, you can mute Mr. Vikas Chaturvedi. It's creating a lot of noise. Yes, Dr. Anu, please.
Good evening, everyone. Welcome to DAW's Super Tuesday Contact Lens Learning course. This is the episode 7. I would like to welcome the expert panel. We have Dr. Jitendra Jethani, sir, Director, Baroda um, Children Eye Care and Squint Clinic, Director, Myopia Control Clinic and Research Center. He has been the ex-secretary and president of Baroda Ophthalmic Society and ex-scientific committee chairman of All Gujarat Ophthalmological Society. He has won multiple AIOS award in research and has various published review indexed articles. He has won various gold medals and best video awards at AGUS, BUS, and SPUSI. He has been pursuing the PhD in myopia progression in children and authored 3 books and written 11 chapters in various books. We also have Dr. Shweta Chaurasia, ma'am. She is the additional professor at Advanced Eye Care, PGIMAR, Chandigarh. She is also a pediatric ophthalmologist, strabismologist, and neuro-ophthalmology. She has won multiple awards for Best Paper in Pediatric Ophthalmology and Squint and Physical Poster Awards, as well as Best Video in NZOS. She has also delivered several faculty talks and instruction courses at various national and international conferences. She is a library come online officer at Chandigarh Ophthalmic Society and has multiple publications. We welcome both the expert panelists for today's webinar. And I would request our speakers.
Dr. Chris will be speaking today. We have introduced both the speakers in our first series, so I think we are not going to repeat that, and it's already 7:35. So let's move on to the second part of the orthokeratology lecture today. And today I think Dr. Chris is going to speak on orthokeratology. So Dr. Chris, please share your slide and the stage is yours.
Very much. I have all the speakers in front of me. Can we? There we go. Okay. Good evening, everyone, and thank you for that introduction. Our first lecture about 2 weeks ago, we discussed basic orthokeratology. So historically, ortho-K, as we call it, was defined as only for myopia correction. During Dr. Arthur's research, he found a way to correct hyperopia, presbyopia, astigmatism, and even post-LASIK. We should therefore redefine ortho-K as non-surgical correction for a wide range of refractive errors and not just myopia. So today we will cover high myopia, hyperopia, and presbyopia.
We are not able to see your
You have
presentation.
you have no
Dr.
PowerPoint.
Chris, you need to share your slides.
Is it not sharing?
That's sharing.
Sorry.
Not sharing.
Shari, can you help Dr. Chris? Shari, are you there?
Yes, sir. It's sharing.
Is it sharing now?
Yes. Good.
This is the same slide. Dr. Arthur Tung and Dr. Johanna Tung and I, we share lectures from time to time. Today it will just be Dr. Tung and myself. So on today's topics, we're going to talk about high myopia ortho K fitting process, lens design, and fluorescent interpretation. We will also talk about hyperopia and the fitting process there with lens design and fluorescent interpretation, which is very different to myopia. And then the presbyopic for both center distance and center near for hyperopia or myopia. So we define high myopia as over -5 diopters and up to -10, although there's some of our colleagues that have been reported fitting cases of much higher than that with the GOV XM lens. So before we introduce high myopic molding, we need to review the limits that we were initially taught. John Mountford, an Australian orthokeratology guru, proposed to predict ortho K effect using the corneal E value. His regression states that for every 0.2 cornea E, approximately 1 diopter of myopia can be reduced. The cornea is really higher than 0.8 or 1 diopter. Using that information, it could be concluded that the highest target power that could, with that information, be corrected would be -4 or maybe -5. And for a long time, -5 and -6 was regarded as the highest amount of myopia that could be corrected with orthokeratology lenses. Dr. Helen Schwarbrick, an Australian professor, pioneered to modify the Munderland's formula for use in orthokeratology. This formula has been widely accepted for the prediction of the treatment zone in LASIK surgery. While it was thought that ortho K is a kind of non-invasive LASIK surgery with the central epithelium thinning and the maximum feasible epithelial depth of 20 microns was available, all that sounded fairly reasonable. They claimed that Munderland's formula could be adapted to derive the 20 microns on epithelium for the maximum reduction of myopia if we're using a treatment zone of 3 millimeters. Using all that information, the maximum deductible myopia would then be 6 diopters. And that used to be the barrier for ortho K for over 20 years. So if this formula then, and 20 microns of epithelium are accurate, then they would be correct. But what have we missed and what were we not taught? So to adapt the Munderland's formula for ortho K and the treatment zone of ortho K was supposed to ablate or undermine just like that the created amount of LASIK surgery. But critics forgot to interpret the topographies a lot deeper. Here we have 3 topographies illustrated. Before showing you resources, you might not differentiate that there are soft contact lenses, post LASIK, or ortho K. They all look pretty much the same. The soft contact lens forms the ablation-like treatment zone all above the cornea, and it has nothing to do with the epithelium at all. So that would be our first image. The LASIK ablation causes from the cornea an indentation central that amount can be predicted by the formula. So ortho K is somewhere between the soft contact lens and the LASIK. The epithelium in ortho K is pushed centrally outward and peripherally inward to form a steep ring. So therefore, the treatment zone is actually straddling the pristine cornea. It is important to realize the reciprocal highlighting of zonal curvatures in eye myopia molding. When we look at the corneal topography after LASIK, the most prominent feature is the flattened treatment zone. Have you been curious about how the red steep ring surrounding the flatter blue treatment zone has been shaped? This ring is not shaped by LASIK. Instead, it is highlighted by the steepened zone after the flattening central zone. So LASIK ablation is undermined from the pristine cornea, which can well be predicted by Manelin's formula without stromal depression. Ortho K is somewhere between the soft lens and the LASIK ablation. The epithelium in ortho K is pushed centrally outward, as we can see on the diagram, or peripherally inward to form a steep ring around the central flattened zone. Here we illustrate a successful molding of 8 diopters on a very flat cornea. The mid-peripheral steep ring in the tangential map is measured at about 3 diopters, which is almost 20 diopters steeper than the central flat zone. The steep peripheral ring ensures central flattening. The image shown now is OCT in a human eye after myopic molding. And you can see where we have thin epithelium, then a negative peripheral force causing epithelial thickening in a round donut ring. We have a positive conformation pressure just outside of the negative force, which creates epithelial thinning. And that's how ortho K is formed. Excessive high myopia of 12 diopters has been used by the GOV group for more than 20 years. It is not necessary to move too much tissue outward from the central cornea for high myopic molding, as was stated by Manelin's formula for LASIK surgery. There is so much tissue in the periphery, and if we use in the periphery and move it inward, form a very steep ring, you would be able to create the changes that's occurred. If with a steep mid-peripheral ring that highlights the central flattening without too much thinning of the central cornea, that preserves the central corneal integrity and health. The graph below demonstrates the forces and the direction that it applies on the cornea for effective molding. So the image right at the bottom on your left-hand side is a high myopic mold, as opposed to the left-hand side, which is a low myopic mold. So we can see that conformation pressure that pushes into the periphery tissue up, and that then creates a high myopic molding, as we see in those curves. That's a normal low, and that's the XM curvatures. And we can see in the XN curve, steep ring that is formed by the peripheral inward pushing of the tissue. Here we can clearly see, comparing the curves, how much different from a -4 to a -8 the corneal topography will be. So effective high myopic ortho-K is not only central flattening, but it's also mid-peripheral steepening, which is very, very important. This differential map shows 8.5 diopters of change. From previous talks, you might be aware that Mulliren's formula is actually predicting the sagittal height difference, the treatment zone and its center. If the epithelium can be supplied from the center as well as the periphery, the high myopic molding will not be as pie in the sky as most people think. Here, we will reformulate Mulliren's formula for use with GOV in high myopia, with the assumption of using 50% of the peripheral epithelium. The 50% of the peripheral epithelium is enough to ensure the safety for high myopia molding on a treatment zone of 3 millimeters to as high as 12 diopters. And we call that Tung's formula. It's well known that molding very flat corneas are extremely difficult due to poor lens centration or insufficient peripheral inward forces. With the traditional centrally outward molding technology, this slide demonstrates how the XM lens can successfully mold an extremely flat 39 diopter cornea, diopters of reduction. This slide shows the comparison of treatment zones width estimated by Mulliren's formula and Dr. Tung's formula. It is obvious that the limiting factor of the treatment zone is the target power, not the optical zone width of the lens. One cannot increase the width of the treatment zone by assigning a larger optical zone, especially when the optic zone has been bigger than the limit of the size of the target power. So we can see, if we look at this, that with Mulliren's formula, if we were treating 6 diopters of myopia, we get a 3.2 millimeter treatment zone. If we apply Dr. Tung's formula, we will have a 4.5 millimeter treatment zone. The XM is a powerful lens, but it's not an easy lens. But we have to ensure that we follow proper procedure, make sure that the appropriate amount of tightness and lens size are essential. For some irregular corneas, we have identified and designed quadrant lenses, which we will discuss in the next lecture. Sometimes for high myopic molding, we would require 2 steps. So after fitting the first lens, when the ring lifts the lens up, the second lens would be fitted slightly flatter to then correct the residual myopia. The GOV XM system can manage very safely and effectively as high as -10. We have had colleagues in America and the UK fit as high as -14 and -16. Fluorescein photo and maps that we have on the screen at the moment, we'll see with a typical bullseye. After molding for 1 or 2 weeks, the second slide, the second fluorescein pattern, shows central vaulting as a tight fluorescein pattern. If you remember the fluorescein pattern from last week, one would be a tight lens that's vaulting the center a little bit. So the map shows a 2 mm treatment zone. That is too small and proves Mullen's formula. The right action is not to give up this case, nor to ask for increase in the optic zone of the size. What we do need to do is order a flatter K-code with a shallower lens sagittal height. And the molding will be improved dramatically, as we can see in the third image. Fluorescent pattern, by going 2 steps flatter, will also be restored to a typical bull's eye flatter code. Knowing the peripheral inward molding, we may predict that 12 diopters could possibly be the upper limit for a 3 mm treatment zone, as we can see here. It is very possible to correct -12 or -15 if the cornea becomes deeper. These images, we can actually show that XM molding is effective for over 10 diopters. And we can also correct an amount of astigmatism. Astigmatic ortho-K correction, Dr. Kun will teach in the next lecture. What we have here is an 8 diopter high myope case with a 41 diopter flat cornea. This cornea can be flattened to 34 degrees to 34 diopters at the center, which will give the patient 20/20 vision. The steep rim, as we can see, is steepened to almost 54 diopters. That is a 20 diopter peripheral inward focusing. A lens like this will be very effective for myopia management as well. To achieve results of all the previous slides and the slides that will come in, we have to remind you that size control is so important. Because as you have seen before, same size, same treatment zone, if the size of the lens varies, the treatment will be very different. Some safety issues. We should always instruct our patients never to wear lenses while they're awake. The optic zone of the myopic molding lens bears on the central cornea that may seal off with central corneal erosion. Lens move too much. The risk of sealing off the lens seems less in myopia, in hyperopia molding, for the lens has central pooling, and I will show you those slides in a moment. We need to remember that we should always manage the patient's expectations. In some cases, in early molding, there might be some night glaring, and that would be a bit difficult when patient has to drive at night. Lens decentration may be induced by lid structures, such as the lower lid that's too loose, or the lower lid margin is positioned too inferiorly to support the lens. The downward shift would be significant if the upper lid is also too tight, which will push the lens downward. It is of no use to replace a tighter or looser lens with this eyelid condition. The only strategy might be to put on the contact lens on the eye just before sleeping. You put the lens on the eye, close the eye, and go to sleep, so that the lens is positioned centrally. To conclude the high myopic section, it is important to note that high myopic ortho-K is achievable by applying the concept of relative curves. The concept of relative curves can also be applied for hyperopia and for other advanced corneal molding. As orthokeratologists, we need to know why high-myopic ortho-K is possible, so that we can broaden our scope of practice. Whilst we do that, not to sacrifice any of the patient's safety. So when I say we need to manage patient expectation, if you fit in a -8, it would be unrealistic to expect that patient to be plano the next morning. It could take 3 or 4 days before they would be fully corrected. Now we can look at hyperopia and hyperopic ortho-K. And for many years, everybody has debated, does it actually work? And then why does it work? And why does it not work? Before discussing hyperopia and even progressive ortho-K, it is important to define the protrusion molding for hyperopia, which is the opposite of ablation molding to reduce myopia. The conventional protrusion molding is carried out by fitting a very tight RGP to exert an inward force on the mid-peripheral cornea to generate a negative suction force at its center for the cornea to steepen. However, it is important to note that treatment with conventional molding to reduce high hyperopia is not possible. So Dr. Tung patented the GOV-H lens with its dual geometric design. This manifests with a plateau zone as an additional curve to carefully arrange an aspheric base curve with reverse zones. The plateau zone may flatten the mid-peripheral portion of the cornea, which in turn highlights the central steepening. And this is what causes the effect of molding higher hyperopia. The dual geometry lens can reduce hyperopia much faster and more reliable and more predictable than before. This lens also ensures a much wider central distance zone for further steepening at its center, and it works well in progressive presbyopic ortho-K. It is important to note that treating hyperopia takes a little bit longer than treating myopia. One of the most common side effects of RGP with a steep base curve is spectacle blur associated with central corneal steepening. The unintentional corneal steepening is very similar to the conventional hyperopic ortho-K. Designing an aspheric base curve may be more effective for this hyperopic molding, but the treatment zone would still be too small and we would get an unpredictable effect. So what is the difference? These pictures demonstrates how different molding zones are with or without the plateau zone. The GOV dual geometry design on the right has a plateau zone, which creates a well-defined and wide zone. This will ensure stable vision in the distance and the base for progressive myopic molding when the patient gets there. While the left picture is shaped by an aspheric RGP without a plateau zone. And we can see from the topographic maps that the treatment on the left is so much smaller than the treatment on the right. The addition of the plateau zone enables the GOV lens to be more effective and more consistent in molding higher hyperopia. So the high myopia molding, we can see that we have an extra curve in the peripheral. Dual geometric lens, or DG lens, therefore refers to ortho-K lenses for hyperopia. The H lens for hyperopia, having an aspheric base curve, may reduce hyperopia up to +6 with one single pair of lenses. The HP lens, which we will discuss a little bit later, could be incorporated as a slightly steeper center, causing a high eccentricity value, which molds a central reading button based upon the far reading zone. Dual geometric H and HP lenses, we will have a steep, flat molding from central to periphery. This exerts a positive force on the mid-periphery portion of the cornea to form a flat zone which highlights the central steepening. This is much more effective than exerting a negative force over the corneal apex in the traditional molding pattern. The dual geometric design ensures a wide and precisely formed far zone, progressive presbyopia molding, and hyperopic molding. This is a diagrammatic sketch of the DG lens, illustrating the features of the steep, flat curves. The left diagram for the H lens and the right demonstrates the presbyopic section, which we add for near vision. Dr. Jennifer Chu's cat study clearly showed us the morphological changes in the corneal epithelium of the cats in her cat study. We can see the epithelium steepening in the center and the mid-periphery, and this was after 4 hours. After 8 hours, changes appeared to be more significant. She found that after 14 days was the most significant change. This is in line with what we find with hyperopic molding. It does take longer to get a full correction as we are moving the epithelial tissue to the center of the lens and piling it up to get the required correction. So to move tissue from the periphery into the center takes a little bit longer than molding myopia, where we push the tissue from the center out into the periphery. For comparison, Jennifer Chu placed a myopic ortho-K lens on one eye and a hyperopic lens on the other eye of the same animal, and she could then demonstrate very clearly the difference, the changes between hyperopic and myopic correction. This is a diagrammatic representation of what happens in a hyperopic ortho-K fit with a dual geometry lens from GOV. The center piled up. So we are pushing tissue from the periphery into the center. Then a plateau zone created around the treatment area. And that plateau zone enables us to treat a greater amount of hyperopia. Sketch on your screen shows the forces created by the GOV hyperopic DG lens. In the center and in the periphery forms a negative suction force, which causes corneal steepening. There are also two positive information forces outside of the negative pressure zones, which shapes the flatter areas outside of those treatment zones. In the hyperopic molding, we can see the reciprocal highlighted areas, as we have said before. The purpose of this is to create a steep center, and outside of the steep area, we flatten the periphery. And on this slide, we can clearly see steep central, then a flat plateau zone, then a steep ring, and flat towards the edge. So it is steep, flat, and an edge. Slide demonstrates the fluorescent pattern of the lens on an eye and the corresponding corneal topography. It's interesting to note that this topography was taken only 2 days after starting the treatment. And we can see that the rings in this particular case are not fully formed yet. Hence, we say it takes time for it to mold effectively, as Jennifer Chu has demonstrated in her CAT study. So this is an excellent example of a hyperopic post-ortho-K fit. The corneal topography clearly shows us the zones that we are looking for. A round and a wide steep center surrounded by a flat zone and then a steep rim. And we can see that we have created a wide, smooth area. Remember that you should always use your refractive maps on your topographer, and that will show you the amount of refractive change that you have created. This is a great tool so you can see if you are creating the correct amount of change. So we said that fitting myopic ortho-K lenses is as easy as 1, 2, 3. To fit a hyperopic lens is just as easy. We need the mean K. We need a power code, and we need the HVID. To fit hyperopic patients, you do not necessarily need a hyperopic fit set, although it is recommended because of the difference in fluorescein patterns. You can use an XMJ or an XM to fit a hyperopic patient. You can use a hyperopic fitting set to fit an XM patient. You would just need to get your over-refraction correct and ensure that the correct size we have and that the K mean is the correct one to use. The lens aligns on the eye, and the only difference is the center. So you would just over-refract and order the correct lens. So this would be ideal hyperopic fluorescein pattern that you need to see with the lens on the eye. The most important zone highlighted by the red ring. This is a plus 7.5 diopter hyperope that was successfully molded. We can clearly see within the red ring, we have a steep, flat, steep fit. And if you get that fluorescein pattern, your fitting would be successful. It is important to remember to insert these lenses like you would insert a scleral lens. The image that you see shows the same lens on the same eye. The right lens has been inserted with saline, like a scleral lens. Hence, there is no central bubble. Once the lens is on the eye, let it settle for about 15 minutes before evaluating it. So it's important to see that the image on the left has a ring, has a bubble in the center, has a bubble in the mid-periphery. That's because there's air trapped under the lens. Remove the lens and reinsert with the patient looking down as if you fit in a scleral lens, and the image would be very different. Following 5 pictures show us how to fine-tune to half a diopter, because half a diopter can make quite a big difference to the fluorescein pattern. The center is an ideal fit with a steep, flat fit with a bright edge. That is the ideal fit. The top right-hand picture is just 0.5 diopters flatter than the center. And we can see that there is less fluorescein in the center of that lens, and there's some bleeding of the fluorescein in the alignment curve outside of the peripheral ring. The top left-hand picture is 1 diopter too flat. And in this fluorescein pattern, we can see that there's very little fluorescein in the center, and the alignment curve has a lot of fluorescein, and it lifted off the cornea in that area. The 2 bottom pictures show the reverse. The bottom right is 1 diopter steeper than the central picture. And we can see that this does not demonstrate any of the desired zones that we are looking for in an ideal fit. And the bottom left is only 5 diopters steeper than ideal. But we can see that in the center, we don't have a defined ring. So will the bottom left give some correction? It will. But the correction won't be stable and won't be sustainable. So we need to have the defined rings, as we see in the center. Needs to be steep, needs to be flat, needs to be steep, and then needs to be flat again. Without that, we will not have stable vision. So, as I said, an ideal fit is a central plateau of alignment. Gentle alignment in the periphery, the same as for myopic ortho K. It's the center that makes all the difference. If we tighten the lens, central treatment zone will increase in size. A lens that is too tight will produce a central lake, almost like a volcanic type shaped cornea. If we loosen the lens in the central treatment zone, this will decrease the treatment zone in size. A lens that is too loose will produce almost no ortho K effect, or a very small zone with lots of flaring. In this slide, we can see the OCT of a post-hyperopic ortho K treatment. We can clearly see positive and the negative forces of the lens and how that has molded the cornea. Tangential topographical map also shows the treatment zones that have not yet fully formed. With a few extra days of treatment, this will improve. So if you are 100% certain that your corneal topography measurements are correct, that you have calibrated your machine, that you have done all your calculations correct, that your fluorescein pattern is absolutely spot on, and you get this, you've got to give it time. I often say that time is our friend, particularly in hyperopic fitting. So this is a study of a 28-year-old male. It's important to note that we need a very accurate refraction, as we said in the myopic treatment. We have a calculator online, as we do for the myopic fit, and we have a calculator for astigmatic and post-LASIK fits as well, as we will do next week. If you do not have a fitting set, which we highly recommend you use, you can put all your results into the calculator and fit empirically. You will have a 70 to 80% chance of getting it correct. Although we say the calculator will give you 70 to 80% correction, we do suggest a fitting set so that you can be certain that your fit and fluorescein patterns are effective. It's one thing to use empirical fitting, but we do not know what the lid forces are. We do not know what the tear quality of that patient is. So whereas the calculator will give you an 80% chance of being correct, there's a very high chance that it might also be incorrect. So we do say use a fitting set, because that is by far the most important way to fit lenses. These two pictures show the results of two lenses on an eye that have been fitted empirically. We can see the zones that we are looking for, and this will correct hyperopia effectively. So there's a high chance, if you order empirically, that you will get it right. But there's also a chance that you will get it wrong. So it's important to have a fitting set so that you can get it right first time. In our lecture of troubleshooting, which in 2 weeks' time, we will explain all of this again. It's so important and it helps to manage patients' expectation. The slide that we have at the moment shows us pre and post hyperopic fitting. We can see that this was done way back in 2005 when Dr. Tong patented his hyperopic fits. The lower images was not fully formed yet, and with time we got the steep, flat corneal topography. With hyperopic ortho-K, we should also think outside of the box. The photos that you see on your screen right now shows how effectively the H lens would reduce +3 diopters of hyperopia to manage an accommodative isotrope. So we should not just think that it's only for hyperopic molding. Let's see what other uses are available for these lenses. Do we say it's okay to fit presbyopic patients? And why we say that GOV has got the most comprehensive range of ortho-K lenses available? Because we can take you from around about +6 to -10 comfortably. And on those +6 to -10, we can correct presbyopia with a central distance or central near lens. And on top of that, of course, we have astigmatic lenses in dual axis or tilted lens, and we have post-LASIK correction. The GOV multifocal lens can correct both myopic and hyperopic lenses. We have had rigid lenses with distance and near through separate zones, on-axis fovea vision and single vision. We've had simultaneous vision on multifocal lenses, either as center near correction or center distance correction, on axis fovea vision and mixed focus. Now we've got multifocal ortho-K. The UV range of multifocal lenses, you can fit the patients with a center distance or a center near, or a combination of both of those. You can do a myopic center near or a myopic center distance. The MP would be a center near, the MP2 will be a center distance. You can do the same for hyperopic patients, either fit them with a center near or a center distant correction. So either hyperopic or emmetropic patients. These lenses work very well with the early hyperop or emmetropic patient as well. We can see from the topography how the small central raised zone will give the patient just enough power to read. This is an example of a center near treatment. This slide shows us center near example, post GOV ortho-K molding, and some of the soft daily wear multifocal contact lenses and monthly wear lenses that are available. And we can see that the design is very similar and therefore as effective as the soft lenses. So how does it work? This is an example of the hyperopic presbyopic ortho-K. The central raised portion, which is created right there, will give the patient good near vision. There is the center near hyperopic presbyopic HP ortho-K lens. This targets spherical power plano with an add of around 2 or 2 up to 250 diopters. Remember, the fit-in is the same as a hyperopic lens. It takes longer, as I've said before, to get a full correction, sometimes up to 2 weeks. Myopic ortho-K correction goes a lot quicker. This picture shows a fine bubble in the peripheral curve. If we find big bubbles like this, the lens needs to be removed and reinserted like a scleral lens and then reevaluated. One must not change too quickly. We need to ensure that you have, if you're absolutely certain that your corneal topographer has been calibrated, that your measurements are correct, your calculations are correct, and you get this, don't just change the lens. Remove and reinsert and check again. This is a repeat of the previous slide. And it is put here simply to reinforce that fluorescent pattern, because it's very different to the myopic pattern. And we need to understand the steep, flat to get good correction. Central near presbyopic ortho-K lens. This, we can target patients from plano to -10, and as I said, slightly higher. You can do an add of 2 or 250. You can do an add of much lower in the early presbyopes as well. The fit-in is the same as fitting either the high minus or the regular minus lenses. So either the XMJ or the XM, you will exact same fitting procedure. The effect of creating a myopic presbyopic molding would take a little bit longer than the regular Ortho-K. But generally, again, 1 to 2 weeks to establish good, comfortable, clear near vision. The multifocal means multiple focal points on a lens, still using the central part of the fovea to read. So let's think outside the box. We use the fovea to read. Maybe not 100%. What about the concept of visual span for reading? A range of letters that is formatted as a text can be recognized reliably without moving the eyes. So we don't use the fovea 100%. We enable parafoveal reading and reserve the center for distance vision. So PVS multifocal can move reading center to parafoveal retina and works very well for presbyopia. This may be a great benefit in myopia management. The PVS means preferential visual span. The concept is to enable the off-axis near image to supersede the foveal image for reading and perception without triggering accommodation. By doing so, we can apply PVS for progressive molding objects. There are 2 factors that determine the eligibility of PVS and the image focus and the retinal resolution of the locus. The resolution of the retina fades out from the central fovea for 20/20 best corrected visual acuity. We can get 20/50 at the outmost edge of the parafovea. The landmarks in the visual angle is 2 degrees to give us 20/20 and up to 5 degrees for 20/50, which can be used to estimate the corresponding zone width in designing PVS devices. If we make the focus nearer than arm's length, the perifoveal area is also a great potential area to create a reading zone. So the PVS multifocal contact lens is designed to manipulate a strong positive spherical aberration in the 1 and 2 millimeter ring of the paracentral cornea, of which the ad is also far stronger than that was used for simultaneous vision multifocal lenses. The same concept can be used in orthokeratology to do progressive molding. There has to be a back contour to form a progressive corneal shape for PVS reading. Illustrated in the top map is a central distance PVS molding, and the lower one is a central near molding. This will give you an impression of how PVS Ortho-K is different from the simultaneous molding. We should remember that there are options for presbyopic correction with contact lenses. We have monovision, we have simultaneous vision, and we have translating multifocal vision. To recap, monovision means fitting the dominant eye for distance and the non-dominant eye for near. The skill can easily be applied to orthokeratology by using single focus ortho-K lenses to under-target myopia or to over-target the hyperopia over the non-dominant eye, while fully targeting the dominant eye. The negative side of this, of course, would be the same. Binocularity would have to be compromised, and this might be unsatisfactory or unacceptable for a proportion of our users. Central near simultaneous multifocal designs are the choice for most soft contact lenses. The drawback is the blurry or fluctuating distance vision induced by the aberration or the interference looking through the central near button. Peripheral near multifocal designs are preferred for RGP contact lenses. The design of these lenses is to ensure clear distance vision while looking through a primary gaze position. The peripheral near design can be simultaneous vision with an aspheric or multi-concentric zones, or translating vision with a near ad position slightly inferior to the pupil for reading in downward gaze. Ortho-K is technically done by RGP lenses. The corneal shape after molding closely resembles soft contact lenses and is totally immobile. It is logical to propose the best choice for ortho-K. So either my hyperopic or myopic presbyopic corrections, we could do central for near multifocal vision. In our experience, central distance and peripheral near PVS progressive ortho-K works very well for high myopic presbyopia to offer them clear, near, and distance vision. While in hyperopia or very low myopia, center near is usually the choice for clear near vision. We may apply central near in the non-dominant eye and central distance in the dominant eye for modified monovision. What is the precision and the control required to achieve a successful molding? It is most important for the lens to center correctly on the eye. Near button or the reading zone must be molded in the center of the pupil area. This shall require a well-sized control lens. The blending zone needs to run from the central near to the periphery of the distance area, and this must be as smooth as possible. The peripheral zone for far vision must be shaped as wide as possible to ensure clear distance vision. This picture demonstrates how a central prolate button can be sharply formed based on the wide and well-defined far zone for hyperopic diode. Patients wearing single focus GOV ortho-K lenses who now becomes presbyopic. We would need to check the K code and the power code to check if they're correct. And all we need to do is use exactly the same parameters of your single vision and add the corrective presbyopic amount for HP or MP lenses. You would order the presbyopic lens with the same K code and the same power code as for far vision. For monovision or modified monovision, the single non-dominant eye is usually the choice in correcting emmetropia. Thank you.
Hello?
Thank you so much for that wonderful lecture. And Any questions, Sarik? You please say that question in the chat box. There are few questions. Sarik, you can read those questions.
One questions we have received, Dr. Manish from Hyderabad. Quadrant-specific designs in GOV2 change the treatment zone size in GOV lenses. And is there any fee from form options will come in future?
Dr.
Sorry,
Chris,
can you
I hope
repeat
you
again?
got that question. Yeah.
Did
Sarik,
not
just read it
understand.
again.
Quadrant-specific designs of GOV2. Is there any change in treatment zone size in GOV lenses? And is there a free form options will come in future?
You mean quadrant design?
Yes.
Okay, that is a topic of next seminar.
Okay, we'll
Not
cover this in our next lecture.
next lecture. Yes.
Yes, there is one question by one of our expert, Dr. Jitendra Jethani, and he himself practices orthokeratology. In high myopic patients, will one have higher order aberrations too? Do we have data to know if the vision quality in high myopic patients, as the zone size would be very small? Dr. Chris, I hope the question is clear to you. You can check in the chat box also. It's there.
So the vision quality definitely is good because it's not a defined zone. The area from the center to the periphery is a gradual move out. So you don't have an exact cutoff point. So you don't have a central distance and a near. With the way it's the PVS where as it's moved out, you find that the vision quality is really, really good.
Jitendra
So,
sir,
yeah,
yes, sir.
do we use the single lens, Dr. Chris, or we use, we flatten the cornea with a larger lens and then try to reduce the zone size in the center? Like we use two lenses, or, we use a single lens and have the flattening effect almost 8 to 10 diopters. Because then it will become very tight if you have such a lens which goes up to 8 to 10 diopters of myopia. It would be flattening the cornea a little too much.
First of all, we have to pile up the tissue at mid-peripheral from peripheral inward, so that there will be tissue for further flattening. So the first stage is that we form a smaller treatment zone and wider peripheral stiffening zone. And then we apply another lens that is slightly lower in sec. That is the flatter in sec. And then the pushing will force the tissue further flatten it at center. But sometimes we can even mold up to 8 diopters with only one pair. However, with the high myopic molding, we have to be very careful for size control because the centration is very important. If the centration is no good, then the molding will be causing a lot of halos or astigmatism at center. So the size control and also the tightness control has to be taken care of together.
Yeah, exactly. That was my question, whether there will be halos and abrasions or not when I was talking about very high myop to be treated with ortho. So how does these two lenses work? Like you use the first the just to make the mid periphery a little bit steeper. You use one lens for a week and then you start using the more stronger lens, or it goes
No,
alternately.
the same base curve should be fine.
Hmm.
But we lower down the sec in second
Lens.
lens.
Yes.
Because when you push the tissue inward, the cornea sec will become higher. And
Yes.
then the lens will be insufficient to push the center. So we have to lower down it and push down the center tissue. That's the strategy that we when you use the first lens, it forms a steep rim, but the center will be like a pushing after you mold the peripheral stiffening, so that the second lens will reform the bullseye pattern and can push down the center. But in some cases, that the high myopic case in an adults, we have to take care that the halo could be an issue if the adult has to drive in the nighttime. So if the molding is successful with 20/20 vision for -8, -10, but actually he cannot drive in the nighttime. So for the kids, there is no problem because they do not drive. But for the adults, we have to warn them that there could be an issue with the high myopic molding.
Sure. Yeah. Thank
Yeah.
you. Thank you, Dr.
Yeah.
Chris.
Welcome. Yeah.
Dr. Shweta, do you have any points? Ma'am, you'll have to unmute yourself.
Thank you, Dr. Krish, for giving such a beautiful insight into the use of ortho-K lenses in hyperopic cases. I have a question for you. If a patient has in one eye, if it is a low myopic presbyopic, and in the other, if it is a higher myopic presbyopic, so you give a central near simultaneous vision design in one which has a low myopic presbyopia and central distance multifocal design in the other high myopic presbyopic. So will the patients have some complaint about the anisomyopia using the ortho-K lenses, or some I mean some headache, or some kind of you are using these ortho-K lenses together?
Do you mean if we use one center near and one center
Yes,
distant, it
central
will cause
distance. Yes,
problem?
ortho-K
Okay.
lenses. Yes.
For most of the cases, hybrid will accept center near better than center distant. So I usually use both sides center near. And even if we mold it slightly mild with the center near, they are happy because they accept the center near, and then they can accept the good vision at near, and then they can sacrifice a little bit the far vision. But for myopic presbyopia, the condition is opposite. If we mold the myopic patient, because they can remove the spectacles and just read with their myopic eyes, they can read very well. So if we mold it, and then when they put down the spectacles, they can see far very, very clearly. So if we mold it center for near, they will be unsatisfactory because they do not want it for the blurry of at far with the lenses. So for the myopic presbyopia, I will be very preservative, that very conservative, that if they can agree that they can sacrifice a little bit the far vision, then we can mold it modified monovision. That means that the dominant eye for far and then the non-dominant eye center for near. So that is what my strategy. And then we have to get their consent that they agree with those. And then we can try it with the spectacle lenses to show them that after molding, you will see worse at the non-dominant eye for far, but you will see better at near. And then if they accept, then we can proceed with the molding. So
Also
the
quite a good-
refraction and pretest is very important for a successful presbyopia molding. It is not only the lens, but also what your patient expect. So some patients may expect that, okay, we can get 20, maybe 20/40, and I'm happy. And then that is a successful case. If they wanted 20/20 for far and J1 or J2 for near, then you do not proceed it.
Okay.
I think also, as Dr. Arthur said, we've got to manage patient expectations. Often
Yes.
what we do is, if the patient's not sure or you're not sure of what you want to do, it's always great to use a soft contact lens as a trial for a week or two to show them what the effect's going to be before you mold the eye. That's really also partly managing their expectation.
Yes.
My another question is like in accommodative hyperopic children, in refractive accommodative esotropias, when you prescribe ortho-K lenses for these kind of children, have you seen in your practice that using the ortho-K lenses, just like myopia, the hyperopic correction also decreases more fast than as you expect by in age using ortho-K lenses? Have you seen this in your practice? Just like the myopia gets controlled, the hyperopia decreases faster using ortho-K lenses in your practice.
You mean use the hyperopic ortho-K to reduce the
Hyperopia.
hyperopia?
Yeah.
Okay.
Moving
That is
towards image
theoretically
acquisition, basically.
Yes, but I don't see a lot of cases that can, because we do not expect that hyperopia will reduce or will not reduce with age. And theoretically, if the peripheral defocus can also manage hyperopia, then the ortho-K molding can create the peripheral hyperopic defocus so that they can reduce the hyperopia. Yes, but actually, I don't see any report about this, because myopia maybe, but I don't see any paper on this. Yeah, so I have no idea whether it works or not. Yeah.
Thank you so much, ma'am, and thank you both the expert panelists for such wonderful discussion. And as I said, we have a contact lens learning course group where we have almost 200 odd registered delegates. Few of them are optometrists. I hope today's lecture must have helped them a lot. And I think we still have two more series on this, and we are going to subsequently cover that. And with this, it's already reaching 9. So let's conclude today's session here only. Thank you, Chris. Thank you, Dr. Arthur. Thank you, Dr. Jethmalani, and thank you, Dr. Shweta. And let's regroup again, maybe after 1 or 2 weeks, for the third edition of this orthokeratology session. Good night, everyone.
Good night.
Good
Good
night.
night.
Thank you.
Good night. Thank you.
Bye.